their chart, they had been on the same dose for 10 years, a low dose, maybe 5 milligrams 3 times a day. And so I started asking these handful of patients, what are they doing differently than my other patients? Why are they able to stay at the same dose and it remains effective for them? And the answer invariably was cannabis. Often they pull it right out of their pocket and encouraged me to take a good smell of it because they were so proud of this medicine they were using. They knew that it was doing this for them. They were very aware of that benefit. So what are our current harm reduction options right now for people that get into trouble with prescription opioids or with heroin? Well, there's 2 options. One is Suboxone, and the other is methadone. These are both opioid replacement options. The whole idea of harm reduction is to give someone a drug that's safer than the other drug that they were using so that we can reduce overall harm. And it's a real alternative to abstinence. While a lot of us might think it'd be really good for everyone that's hooked on painkillers right now to actually get off them entirely and stay off them and not take any drugs, that's not realistic for most patients. Most patients need some type of replacement or some type of harm reduction approach. And so looking at some of the data on the effectiveness of these 2 standard treatments from a Cochrane database review in 2014. So Suboxone, it was found that only the highest dose allowed, only the 16 milligrams, was more effective than placebo in suppressing illicit opioid use. Low dose and medium dose didn't work any better than placebo. So I shouldn't say it didn't work because placebo also works a little bit. And I do want to draw attention to the fact that we all have an inner pharmacy that's capable of producing both endocannabinoids and endorphins, molecules that are similar to morphine and similar to opioids. And we can make these for ourselves with the power of belief. The placebo effect is powerful. If we look at methadone, it was found to be superior to Suboxone in retaining people in treatment, but no more effective at suppressing illicit use. So what about cannabis for harm reduction? Well, first of all, it has a better safety profile than methadone or Suboxone. It's certainly possible to overdose on methadone. Suboxone is a little harder to overdose because it contains a small amount of an opioid antagonist. But if you use Suboxone, especially with other drugs like Valium, you certainly can overdose on it. Cannabis has a lower risk of dependence than any other psychoactive substance, and a far lower risk of dependence than methadone or Suboxone, which means that if someone was able to use cannabis for harm reduction, they would likely be able to stop the cannabis if they needed to, or take a break from it without any formal treatment. Cannabis, when used as a medicine, especially when it's prepared as a medicine and not necessarily smoked, has an even lower risk for abuse and aversion. And I'm not saying that smoked cannabis is not a medicine, but what I would like to point out is that when we smoke cannabis, it feels really good. And for people that have an addictive personality or have a history of addiction, anything that triggers a reward in their brain, especially an intense euphoric reward, can reinstate reward-seeking behavior. And the patients that have good insight into their addictive tendencies are aware of this and careful to avoid things that are too pleasurable and too rewarding, lest they fall back into reward-seeking behavior. In the studies that have looked at nabiximols, which is GW Pharmaceuticals product Sativex, and I'm not a proponent of that, I'm not supporting that product. I think it's one example of cannabis prepared as a standardized medicine, and thankfully we're seeing more and more examples of that over time, both in the pharmaceutical world and in the over-the-counter and the herbal and artisanal world. But if we look at the data on nabiximols, they have 30,000 patient years of data that have found no evidence of abuse or diversion. That's a lot. So that preparation really isn't being abused or diverted. It's just not likely to happen with cannabis. Medical cannabis laws have not only shifted the amount of opioids being prescribed, they've also shifted the amount of opioids being abused. This was a study that a lot of you are familiar with from 2014 that looked at different factors that might affect how many people are dying from an opioid overdose. And they looked at things like a prescription drug monitoring program, which most states now have. It's something where the physician can look up online and see, did my patient fill a prescription from some other provider, or did they get double the amount by accident, or whatever. That did not help at all with overdose deaths. Here's the odds ratio. And so it actually seemed like states that had the prescription monitoring program, they had an insignificant change. Here's the 95% confidence interval. So if it crosses 0, it's not a significant effect. A law requiring a pharmacist to request patient identification, insignificant effect. Increased state oversight of pain management clinics, also an insignificant effect. But medical cannabis law reduced overdose deaths by 24.8%, and that was significant. This is a huge reduction just by having the cannabis law, not even having an indication within that state that we could use cannabis to treat opioid addiction, even though a lot of people are clearly doing that. It's just amazing the evidence that we have right now showing that cannabis is a solution to this major epidemic. And finally, we had a nod from the federal government for the first time that it's okay to use cannabis and opioids together. Back in March of this year, they released new guidelines for opioid prescribing. These are not mandatory guidelines. Basically, the CDC is hoping that doctors will read these guidelines and abide by them, but there's certainly no enforcement. But if you look closely at these guidelines, in the section that talks about urine testing, they state that clinicians should not test for substances for which results would not affect patient management, or for which implications for patient management are unclear. For example, experts noted that there might be uncertainty about the clinical implications of a positive urine drug test for tetrahydrocannabinol. So there have been so many patients in this country that have been taking their opioids exactly as prescribed, using cannabis with their opioids because they know it helps. They go back to their doctor, they get a random urine sample, the doctor finds THC in there and says, you violated your drug contract, you're out of here. Good luck finding meds. Here's a list of all the other pain doctors in the state. And it's just not realistic for most patients to find another doctor. So again, some of these patients may be best treated with a combination of opioids and cannabis. And this practice of just turning them out to the street to go buy prescription drugs or heroin if they can afford the black market prescriptions is completely unacceptable. Just because they have THC in the urine, just because they're doing something that's safer than using opioids alone. So it's my hope that this little sentence from these guidelines will make it into the awarenesses of pain doctors all over the country. Here's a survey from 2015 that basically just shows that people are, in fact, using cannabis as a substitute for alcohol, illegal drugs, and prescribed drugs. And of these 473 people, 87% of them were doing some type of substitution. They admitted that they were using cannabis to help substitute some other substance. Cannabis has been shown to improve treatment retention in a naltrexone treatment program. So this is a treatment where patients are getting an opioid blocker. And it means that even if they did kind of fall off the wagon and go shoot up or go take some pills, that's not going to affect them because they've already got this opioid receptor blocker in their system. So it's kind of a deterrent that helps them stay on track with their abstinence-based treatment. And so in this study from 2009, it was shown that people who were intermittent cannabis users were more likely to stay in treatment. Those people lasted 113 days in treatment versus those that were consistent cannabis users. And I'm not sure why they stayed in treatment not quite as long. And then the abstinent cannabis users, people who didn't use any cannabis, only stayed in treatment 47 days. So less than half the time of the people who were using cannabis intermittently. And my hypothesis is that this occurs because people that are using cannabis are able to treat the symptoms for which they were originally using opioids, whether it's pain or PTSD or some other issue. People that end up getting into opioid abuse usually have something that could benefit from cannabis treatment. They have symptoms that are making their quality of life poor, whatever they are. This also found that the intensive behavioral therapy helped the consistent cannabis group, but not the abstinent group. Now again, these numbers are very impressive, right? 113 days at best retained in treatment. So, and this I think just points out that while abstinence-based treatment is great for some people, the vast majority is not enough for them. They do need some type of replacement, medication replacement, or harm reduction. Opioid withdrawal symptoms, pretty much every one of them is on the list of symptoms that cannabis can relieve. Nausea, vomiting, diarrhea, cramping, muscle spasms, anxiety, agitation, insomnia, runny nose, sweating. When I was in residency, we actually had a 4-drug cocktail consisting of a diarrhea med, a nausea med, muscle spasm med, and antihypertensive or blood pressure medication. And we would give all 4 of those to help someone get through the first week of opioid withdrawal, which is quite uncomfortable, but I would like to mention it's not fatal. So unlike benzodiazepine withdrawal, someone who's going through opioid withdrawal is not going to die from those symptoms. It's just going to be very unpleasant for them. Well, cannabis, this one herb that's safer than that cocktail of other 4 drugs, they can relieve all of these symptoms. It's ideal for opioid withdrawal. And that was proven in this study that looked at giving THC, synthetic THC, at a total of 30 milligrams a day versus placebo to patients who are going into this abstinence-based treatment. This is a long-acting version of naltrexone that was injected. It lasts 4 weeks per injection. And so here on this chart, you can see the severity of the withdrawal symptoms in the group that received the placebo versus the group that received the THC. And during these first 5 or 6 days, which is really kind of the most important time for someone to get through the opioid withdrawal, the THC did relieve their symptoms in a significant way. I think the herbal cannabis might have done even better than the synthetic THC. But again, what's really interesting in this study is that 100% of the cannabis users, not the people that got the THC, but the people that were using cannabis in their lives separately from the study, 100% of them came back for their second injection, whereas only 46% came back for their second injection if they weren't using cannabis. That's a big difference in treatment retention. A study from 2013, 91 patients found that cannabis users were spending less on their opioids at the beginning of a methadone treatment and that they had less withdrawal severity. So not a very strong study, but unfortunately there aren't that many very strong studies that have looked at cannabis as a treatment for opioid addiction. We have a lot of data on cannabis for pain, and including cannabis for pain in the context of opioid dependence or opioid resistant pain, but not a lot for straight up opioid addiction. Here's one more that we do have. Actually, this data was presented but unpublished, but there was similar data from California from the year before. This is from Denver, and the data was a little bit more compelling. 357 patients who were opioid injectors. They were using heroin, over 18 years old. They had injected within the last 30 days because and that was confirmed by signs of recent venipuncture in their elbow, in their antecubital space. They were not in methadone treatment at the time of the study, and they were touch base with at 6 months and then at 12 months. And what this shows is that the estimated monthly injection count decreased significantly in the people that were using the most cannabis. So this solid line is a high marijuana use group. They started off at a baseline of 120 injections per month, and they came down here to around 50 injections per month. Here's the medium marijuana use. Started off a little bit higher, but by the end of the year it came down quite a bit. And here's the low marijuana use. So the amount of marijuana use makes a difference. The frequency of use, I think the people that are using it every day are likely the people to benefit the most from it in reducing their use of illicit opioids. Cannabis dependence isn't real, kind of. I think it's real to some people, but I think that the data is exaggerated. Here's a classic, figure that's so commonly quoted that 9% of people that use cannabis are going to become dependent sometime in their life. Well, that's certainly lower than the other drugs on this list, but I believe that quite a bit of that 9%, those people were probably in drug treatment programs that were mandated by a judge, not because they really had a problem and they were seeking help with their problem, but because they were forced to because they got busted. I think a lot of us that are in the clinic seeing people that are using cannabis and also people that have cannabis in their social setting know that people really can stop if they choose to. It tends not to be something that we're dependent on, but